I think I remember the horse and cart as well. Yeah, so I was just about to get them out. Lovely, thank you. So painting the policy picture. Policy needs to guide practitioners to conduct practitioners' conduct in an accepted way. What does that mean? Most policies that I've come across in NHS hospitals are not read. So people like us will write a policy on clinical engineering management and we'll present it to the relevant executive management group who will approve it, and then it will sit there. And for the last 15, 20 years while I've been in management, it's been frustrating me. So I decided that I was going to do this doctorate, and I started it about 4 years ago. I finished it this year. And my research project was in policy and policy compliance. And that's what this presentation is based on. So in 1999, when I was reading past research papers, I wanted to try and focus on what is the solution to improving medical devices management. And some of the things that have come out in the past seem obvious. Like in 1999, the National Audit Office in the UK said that only 12% of trusts had a policy on standardisation of medical devices. And they recognised it was a very long document, NAO 475. But basically the document recognised mismanagement of healthcare technology in the National Health Service in the UK. The other interesting thing is that 70% of trusts that had purchasing committees, only half of them had a responsibility for the formation of policy on medical equipment standardisation. And what's the risk of not standardising? Well, the risk of not standardising is patient harm, patient death, more cost. And the more I read, the more I realised that this is still a problem. So in 2004, the National Patient Safety Agency also did a piece of research which recognised uncontrolled purchasing and poor device management. There was also a lack of competency-based training, and these were contributing factors in causing incidents. And in the UK alone, we're averaging around 400 to 500 deaths a year as a result of incidents involving medical equipment. Some of them relating to maintenance, the majority of them relating to the use. And over 10,000 serious harm incidents relating to medical equipment. So also the MPSA in 2004, as part of this report they issued, said that 93 trusts expressed an interest in participating in their pilot study, which concentrated on infusion devices, because they recognised that infusion devices were causing harm and also causing a lot of cost. So it was interesting that these 93 trusts expressed an interest to take part in the pilot, because it showed that they also had an issue. So after these reports, and there were other reports, in 2006, the UK Medicines and Healthcare Products Regulatory Agency issued a document, DB 2006-05, which was a management advice document on the management of medical equipment. It covered areas such as acquisition, training, decontamination, maintenance, record keeping, and the National Health Service Litigation Authority based a lot of its risk management standards on this document and recommended to NHS organisations that they should include the recommendations from the MHRA in their policies. The World Health Organization issued a resolution in May 2007 stating that healthcare providers should establish priorities in the selection and management of healthcare technologies. It's obvious to us as clinical and biomedical engineers that we should have standardization. Selection and management is important. What's the specification of the device? The previous speaker was showing a trend in complexity of devices where there is no need for complexity of devices, but there's a demand, maybe sometimes from clinicians, sometimes from nurses, to have more bells and whistles. But are they actually necessary for what we're doing with them? In 2011, the World Health Organization did a very interesting piece of research, and they said that a number of studies have shown that between 39 and 46% of adverse events resulting from the misuse of medical devices take place in the operating room. Well, there's no surprise there either, because usually 60 to 70% of the equipment in an acute hospital is in the operating theatres. Although the cause was indicated as operator related, I think it goes deeper than that. It goes into the purchasing regimes within organisations, and I'll talk about that in more detail a little bit later. But variation in medical devices between hospitals and even within the same hospitals causes incidents. And I've been in hospitals recently, in hospitals where there are very good clinical engineering managers at very high level who understand standardisation, who understand medical devices management, and yet there's still a wide variety of devices across the same technology group in their hospitals. And the cause of this is usually either a lack of capital to replace the equipment, or the variation in budgeting techniques within the organisation, so too many buyers. So 3 facts emerged from the research done by the World Health Organization. Devices are sometimes not well designed, either over-specified for the need of the patient. The user is often not trained. I've come across this myself. I've been in the coroner's court twice in the last 2 years because a patient has died, because somebody has not used the device correctly, or in one of those instances because they didn't know how a device parameters changed. So it was a syringe driver, patient died, the syringe driver was set at a low rate, and yet when they came to the patient, it was set on its maximum rate. So somebody had tampered with the device, but it was never discovered who. So these things happen. They happen all the time. And in some instances, we don't even know they're happening because they're either not reported or because the clinicians or the nurses don't know they've made a mistake. And it's our responsibility to try and do something about this, which again is why I did this study. So the World Health Organization also stated that effective medical equipment management could avoid 30 to 50% of additional cost for extra spare parts. So with regard to the maintenance, which I'm sure a lot of us are involved in, that's an interesting parameter, because it's a large part of my costs across the 168 hospital sites that I manage. 20 to 40% of the equipment remains underutilised or unused. And now I also see this when I was doing my research and in other pieces of work I've seen done. In the UK, often 50 to 60% of the equipment is lying idle. Now, I went to India about 18 months ago, and I went to visit 3 hospitals there, and less than 5% of the equipment is lying idle. So it shows that you can have good equipment utilisation. Now, obviously, there's a difference in the availability of money to buy equipment, and it was interesting to see that when I went there, the equipment was all in use. There was nothing wasted, and most of the equipment that was not in use was in their biomedical equipment workshop. So there are other things that cause that could be a benefit that the World Health Organization picked up around unplanned costs, lifetime of the equipment, better maintained equipment, better specified equipment. You can tend to use it longer. 25% to 35% of equipment out of service. I recently did this talk at another conference, and one of the questions that came back to me was, well, surely this is the World Health Organization, therefore this is only happening in third world countries. Well, no, it's not. I've been in hospitals myself. When I was doing my research, I visited a number of different acute hospitals in England, where I went into biomedical workshops and found equipment that was up to 3 years old, that was still waiting for repair. I found workshops that had over £1 million worth of equipment waiting for repair, and this was either because the technicians weren't trained or because there was insufficient workforce. But that was equipment out of service. There were other reasons why equipment was out of service. So you can go on towards into departments where the staff don't know how to use the equipment, so they don't use it. And I think these are all things that we need to be thinking about. In the UK, there was a scandal in the news from a particular hospital, and it was the Mid Staffordshire NHS Trust, where they discovered a lot of patients were dying and being seriously harmed through very poor clinical practice and poor management. And in December 2011, there was a statement in this report saying that there was no routine follow-up on compliance. So the trust themselves, the hospital themselves, were not really looking at what the regulations were, not looking at what the standards were, didn't see it as their responsibility. Now the CQC, Care Quality Commission in the UK, who are there to enforce and audit against regulations, attributed this in part to them not having the relevant expertise, i.e. the people who were responsible for delivering the medical equipment management weren't qualified or trained, and the senior management didn't see medical equipment management as an important part of their business because it was a very small slice of their budget. So poor practice is harmful and expensive, and best practice is guided by policy, is safer and cheaper. But the policy needs to be applied. And one way of doing this is once you've got your policy, is to make sure that somebody goes out and trains the staff, trains the management team who are responsible for the budgets in how to apply that policy and then monitors it. So poor governance leads to non-compliance with regulations and all these risks that I've described. One of the interesting things is that when you look at the research, over the past 15 years, 20 years, there's been very little difference in what the research is saying. And I think this is because different parts of the organisation tend to work in silos. The procurement department does procurement, the training department does training, the maintenance department does maintenance, and the governance department does their governance. And they tend not to work together, they tend not to bring all their combined knowledge in a way which can benefit the organisation. So the question I ask myself is, how can we impact on medical devices management policy to ensure stakeholders meet the needs of the regulators, the organisation, the patient, and then deliver best practice improvements? There are external demands on policy. They can, in the UK, they come from the National Health Service Litigation Authority, the Medicines and Healthcare Regulatory Agency, the Care Quality Commission, the European Union, and I know that there'll be external demands on policy from the European Union and other regulatory and standards organisations within Ireland. So there are also internal demands. So the politics and the dimensions of policy within an organisation require that you look at the external demands and the internal demands to say, how do we buy, how do we use, how do we maintain, and how do we manage medical devices policy? And these things all need to be linked with the overall aim of underpinning that policy so that when we buy devices, we understand what the specification is for the needs of the business of the organisation. But none of the organisations I visited when I was doing my research actually specified equipment. None of them. Other than what the clinician wanted for use. So the specification came from, what do I want, not what do I need. So when I'm talking specification, that's not the clinician or the nurse saying, I need an infusion pump and I want it to do this. It's about what does the patient require and what does the business of the organisation require, which is a different question around specifying. So when you're buying devices, it's important to have a plan. And the average acute organisation will have 300 to 400 different technology groups. And what we found was that within large organisations, one of the organisations I went to had over 16,000 devices. And they told me when I first went, yes, we've standardised. But actually we've got a calculation, it's a mathematical calculation we can do across technology groups. And when we actually analysed their asset, we were able to prove to them you have not standardised, because a variation index of 1 is perfect, and their variation index was anything between 2.5 and 16, depending on the technology, which says they had a long way to go. So this, for me, covers the overall aims of a policy, that it should include how do we buy, how do we train, how do we maintain, and then that wraps up the whole policy in a governance framework. And then I'm trying to show there that a policy should be a living document. It should be being monitored at all times. But that's not really the way it works in reality. Policy tends to sit there for when it's first written. People understand it a little bit, they'll do a little bit, and then unless they're trained and they really understand in depth what that policy means, it tends to go no further, and people keep doing things the way they've always done them. One of the issues in the UK, and I'm not sure if it's the same in Ireland, is there are multiple budget lines. A consultant, so you can have 20 consultants working in operating theatres, and they all have their own budget lines, they can all buy. Every nursing manager has their own budget line, they can all buy. And this leads to variation in purchasing and lack of standardisation. And what we're doing across some of the organisations we work with is to create medical devices committees, where they're the only committee that is allowed to approve purchases within the organisation, so it can improve standardisation. These purchasing committees then become the centre of activity for looking at charity funds, NHS funds, anything that is supplied free of charge, rentals, patient-owned equipment, or even equipment that's being transferred into the hospital from another organisation. So I've put procurement in red there because I believe that procurement is at the centre of everything we do as clinical engineers, biomedical engineers. Also, I think that we need to understand what a technology group is, and we should procure by technology group, not by device. And this is a big ask, because you can have a technology group which has maybe 100 pieces of equipment in a technology group, and it could be across 2 or 3 different organisations which are part of a hospital group, or even in one of our hospital organisations, 32 hospitals in one organisation that we look after. And to try and then procure by technology group across the whole organisation is a very difficult thing to achieve, especially if they haven't been doing that for the last 50 years. And you've got that variation to deal with in technology group, and then you've also got variety in age as well as variety in model. So this is a model that I came up with. I believe that procurement should be at the centre of healthcare technology management and policy. Often it's not. In the UK, they regulate, the government regulates on training and maintenance. So there are regulations for training and maintenance. There are no regulations for procurement, but unless you get the buying right, nothing else will come right. Okay. So keeping a policy alive to guide conduct. So policy should guide conduct. And they can be complex things, or they can be quite simple things, but whatever that policy is, you must make sure that the stakeholders are aware of it and actually adhere to it. So the benefits from applying improved healthcare policy: reduced asset size, reduced maintenance spend, reduced spare parts spend, improved user training, improved governance, safer practice, and in the UK, potential VAT claim. Through the way that they can purchase. So ultimately delivering improved patient care at lower costs. And this is just the whole thing wrapped up in one picture. Thank you very much. Am I all right, everyone? There you go.